Okay. Welcome participants to the Warrior University, an online platform for curriculum-based education. My name is Dominique Goodson, and I am a staff member of the Sickle Cell Consortium. I would like to introduce Dr. Eckman and his presentation, Bone Health and Avascular Necrosis in Sickle Cell Disease. Everyone, please give it up for Dr. Eckman and his wonderful presentation today. Dr. Eckman, you have control.
Thank you. Can you hear me? Can you hear me and see my screen?
Yes, Dr. Eckman, we can hear you and see your.
And my pointer is moving?
Yes, it is.
Okay, great. So I'm going to get started. Thanks again for having me back. I really appreciate the opportunity. And tonight I'm going to talk really important issue in sickle cell disease. That really is bone disease and bone health. And I'm asked to talk about avascular necrosis or AVN, but I'm going to expand that a little bit and talk about some other very important issues that come up in individuals with sickle cell disease. Before we go past the first slide, I want to talk about a couple terms, and they're tongue twisters, and I'm going to shorten them down. The first one is called osteonecrosis, and osteo means bone, and necrosis means death. And so this word is a very fancy way of saying that the bone is dying, and that means that it's not getting enough blood supply or nutrients to keep it healthy, and the bone cells die. The same process has been called a number of other names. Avascular necrosis means that the bone death is occurring because there's not enough of a blood supply. And this is shortened to AVN, which I'm probably going to be using most of the time during the presentation. There's another term you may hear occasionally that's called aseptic necrosis. And that really is an old term that really isn't being used. It literally means necrosis of the bone without infection. And in a minute, I think that'll be clear why we separate that out. But I think probably avascular necrosis is the most useful term and most commonly used when people are talking about the disease, except when they publish literature. I don't have any relationships with industry that would compromise this presentation, and I'm not going to talk about any off-label use of medications. So tonight, I really want to help you understand how sickle cell disease affects the bones. I want to also stress how common vitamin D deficiency is in sickle cell disease and understand how that might contribute to bone disease and sickle cell pain. And then finally, we are going to talk about AVN as it affects the hips and shoulders, and then spend some time talking about how this should be managed by yourself and with the help of health professionals. So this is going to really stress what you can do to keep your bones and skeleton healthy. Now this is, we're going to be showing you a lot of x-rays and stuff, and that's a little complicated, so I want to really break some things down. This shows on the left side here, we have the skeleton, and all of the bones in the body have a very rich blood supply. And with sickle cell disease, the blood vessels are caught in the bone, so the blood vessels can't relax. So when sickling occurs, the bones are one of the areas of the body where very commonly there's not enough oxygen or nutrients getting to the bone, and that causes pain. So one of the biggest things that occurs related to the bone and sickle cell disease is the pain crisis, because that really reflects in general the fact that the bones aren't getting enough oxygen or nutrients throughout the body. That causes them to start aching, and then as it gets worse, the pain gets even more intense. Other parts of the body really, in sickle cell disease, really are targets for sickling in the back, the shoulders, and the hips are areas that can cause problems that are separate from just the pain that occurs during crisis. And on the right side shows a close-up of the shoulder joint. And the scapula is sort of a wing-shaped bone that's in the back of the rib cage. There's a clavicle that holds the shoulder to the chest wall. And then this is the head of the humerus, which is the long upper bone in the arm. And with avascular necrosis or AVN, the shoulder is one of the common places you have a problem. The other joint that's targeted for more complications with AVN is the hip joint. And the hip is a joint between the pelvis and the femur, which is the major bone in the lower leg. And so this joint between this pelvis and the femur is another area that's targeted. And so we're going to be talking a lot about that later. But we're going to be talking really about the whole skeleton tonight, because it really can be affected. Now, the skeleton really, problems with it really manifest themselves very early in life. And this is an infant who's only a few years old, who has what's called hand-foot syndrome. And hand-foot syndrome is a painful swelling of the hands and feet, and shown up in close-up here, that where the dorsum of the foot is, the top of the foot and the top of the hands are very swollen, and they're very painful. If you look at the X-rays of the bones are actually dying. They're dying. They're necrosing because they're not getting enough blood supply because of the sickling. So the result of that is that the hands and feet are very painful. You can see the child has a tear here, and this is a very uncomfortable problem for them. It usually occurs only in the first few years of life, and after an age of 3 or 4, this is very, very uncommon or rare. The frequency is upwards of 3/4 of children, and in fact, before we did newborn screening, this was the most frequent way that sickle cell disease was diagnosed, because the child would present with this swelling of the hands and feet, and the clinician would know that this was related to sickle cell disease and then do the testing. Now we do newborn screening, but still at least half of children will experience hand-foot syndrome early in life. It's easily treated. It only requires hydration and pain control, and usually with simple things like Tylenol and medications like ibuprofen. And there's total recovery. All of the bones heal up, and there are no long-lasting changes in the bones or in the soft tissue in the hands and the feet. And so this damage to the bones is perfectly reversible, and usually the child will have an episode or two and then have no more problems in their life. Now, every time you have a pain crisis, as I said earlier, most of the pain is coming from the fact that the bone isn't getting enough blood. If that compromise to the blood, if the blood flow is stopped long enough, there's actually damage to the bone. That's what this white stuff is here. That's resulting because the blood supply was compromised or stopped for a longer period of time, and the bone is actually damaged. This is called the bone infarction, and this is really important to recognize because it is a fairly common complication of pain crisis. The pain becomes localized to one area, often the shins or in the long bones of the arm. It's often accompanied by heat and inflammation with swelling, and it's very often confused with infection of the bone, which is called osteomyelitis. But this isn't the result of infection, it's just the result of the blood flow stopping. The other characteristic here is that this can last for a long period of time. It usually lasts many days, sometimes several weeks, or even occasionally a month or two. And the pain is significant, and it is something that is uncomfortable, and individuals don't understand why their pain crisis isn't away. The treatment is with non-steroidals. They really do target the kind of pain that occurs when the bone is not getting enough of a blood supply, and they are really the best treatment for bone pain. You also want to rest the area. Applying heat will sometimes help improve the blood flow. The bottom line is it takes patience, because this will resolve completely. The bone will heal and the pain will go away. But as I said, it doesn't happen overnight, and it often takes several days to several weeks. Now, osteomyelitis, or infection of the bone by a bacteria, is also quite common. It looks very similar to the avascular necrosis when we do x-rays and all sorts of different type of imaging studies. And sometimes the only way we can make the diagnosis is by putting the needle into the bone and fluid out and putting it in for culture. This is caused by a bacteria, and it's very commonly caused by bacteria that other people get when they have bone infections, like staph infections and other organisms. But the sickle cell patients really are especially susceptible to salmonella infections, and this becomes important in your life to not have pets like turtles and lizards that carry salmonella. Making sure eggs are cooked well before you eat them, and not doing what I used to do when I was a child and eat the raw cookie dough before it was cooked. And eggs are another source of salmonella, so you have to be cautious with that. The treatment is with antibiotics, and sometimes surgery has to be done to remove some of these areas of damaged bone, so that the antibiotics can do their job of clearing out the infection. Now, the other thing that's extremely common is osteopenia or osteoporosis, and that's just a fancy way of saying that there's not enough calcium in the bone. And this shows a X-ray of the spine, and instead of being nice and solid, it should be sort of like this area here. You can see that there's lots of clear areas. The white is the bone, and the clear areas are areas where there is no bone. And when this occurs, the bone becomes weak, and you can see here that there's actually been collapse of the bone. This occurs in older individuals who don't have sickle cell disease, but it's quite common in young individuals with sickle cell disease. And in fact, it's so common that a radiologist can look at a spine film and tell that the individual has sickle cell anemia. It's that prevalent, and it's that characteristic. So it's very common in children. It's extremely common in adults, almost universal in SS disease and S-beta thalassemias, and still quite common in SC disease. Certainly there's increased chronic pain, and so chronic backaches and increased pain with motion in the back are kind of common in sickle cell disease. There's actually a risk of fracture in the vertebrae. They actually collapse and wedge down. But it puts you at risk for breaking other bones in the body, and that's one of the problems related to the skeleton sickle cell disease. There's an increased risk of fractures. You've probably heard about medications that postmenopausal women take to stop osteopenia and osteoporosis. Those have not been proven to be effective in sickle cell disease, and we're not clear whether it would be a good idea to use those. But there are some things that you can do to prevent this from occurring. And one is to treat vitamin D deficiency. And vitamin D is a very, very important vitamin for the skeleton. And vitamin D is responsible for keeping enough calcium in the body so that the bone has enough calcium, and it forms normal density and doesn't become doesn't have osteopenia or osteoporosis. And in sickle cell disease, vitamin D deficiency is extremely common. It's been called the sunshine vitamin. About half of the vitamin D that we get comes from our skin and is made by skin cells in response to being stimulated by sunshine. Individuals with sickle cell disease often don't spend as much time outside as other individuals. And the pigment in the skin also blocks the sunlight from forming vitamin D. And so this sort of sets individuals with sickle cell disease up for having vitamin D deficiency. And the reports in children are 50 to 50%. In my practice in adults, almost everybody I tested for vitamin D deficiency was deficient, many of them severe, and it was so common that we actually stopped testing the vitamin D level until we've supplemented the individual. So if you have sickle cell disease, you should definitely be screened for vitamin D deficiency, and you should be on supplement if deficiency is found. And it's very important that the vitamin D level be followed and make sure that it stays in a normal range. And there's a lot of different ways of supplementing the vitamin D, and I'm not going to go into that. Vitamin D is often given in combinations with calcium, and these are acceptable for sickle cell patients, but most individuals with sickle cell disease need much more vitamin D to get from these combinations, and so they require pure vitamin D pills. And I'm not going to go into dosing. That's something you should discuss with your physician, because I need to adjust it based on your calcium level and your vitamin D level, but certainly you should be screened for vitamin D deficiency. And I think that all individuals should be on supplementation, and the dose will vary by the amount of deficiency that's detected with the blood tests. The other thing that's occurs is that it's becoming apparent that vitamin D may also improve pain and sickle cell disease, and this may be related to bone health, but it also may be related to other benefits that vitamin D have. And vitamin D is a wonderful vitamin. It has many other positive side effects that are beneficial. Some of these include controlling inflammation and making individuals more resistant to infection. And so vitamin D health is really important for individuals with sickle cell disease. Now I'm going to stop there. Are there any questions? This is basically what I'm going to say about general bone health. And if there are questions, I'll try and answer them now. But again, I think I'll leave plenty of time at the end for to answer questions.
There are no questions at the moment, Dr. Eckman.
Okay, I'll go on then. Okay, now I'm going to talk about avascular necrosis, and unfortunately, to understand what happens here, I'm going to have to make you all into radiologists, which are doctors that specialize in reading X-rays. And this is a slide of the skeleton of an individual with sickle cell disease. And this is the spine I've shown you here. And this is the pelvis. And this is the femur on the right and on the left. And what you see here is this is a normal joint between the femur and the pelvis. And there's a nice clear area here that represents the cartilage between the head of the femur and the socket, which is in the pelvis. You can see there's a little bit of density along the top of the pelvis that gives strength to the pelvis so that when you walk, the femur doesn't slide up into the pelvis. And then the head of the femur has a very smooth contour and surface. Now over on the left side, you see something entirely different. This is relatively advanced avascular necrosis, or AVN. And the first thing you see is that there is a loss of the smooth contour of the ball of the femur, and the bone is collapsed. The neck of the femur has actually collapsed on itself. There's a lot of sclerosis or increased bone right along the joint space where the cartilage is. And you can see this area of cartilage is being damaged and destroyed. There are also some clearer areas in the bone, and these are areas where there's cysts form, where the bone has actually died, and then there's a clear space that results from just the fat being there in the bone marrow. And so this is what avascular necrosis looks like, and this is a classic X-ray, and really all you need to be able to follow the patient. The other thing you can see here, there's a few little bright spots in the bone, and these represent old situations where there has been bone infarct that have healed and had a little bit of increased bone density in those areas. So AVN is relatively common. The incidence has been looked at in large populations, and it's from 3 to 50% of individuals, depending on the studies. It occurs because of blocking the blood flow from sickling, and the blood supply to the head of the femur and the head of the humerus, which is the main shoulder bone, is really very tenuous. That is, the blood vessels are quite small, and the areas are very, very susceptible to problems because there's not enough blood getting to the area of the head of the femur or the humerus. And so that's why this area in the skeleton is sort of a target for this occurring. The blood vessels just are very, very small and long, and so sickling is very prone to occur. And there also appears to be increased pressure in the middle of the bone, marrow, and this pressure further slows the blood flow so that there's even less oxygen and less nutrients getting there. And with more and more damage, there's blood clotting, there's inflammation, and blood vessel lining changes that actually lead to the bone death. And so you get into sort of a vicious cycle. Not enough blood supply, that's causing damage with inflammation. There's release of things that cause the blood to clot, and that further slows the blood flow, and you get into a cycle that results in the bone actually dying. In addition to the blood flow problems, both the shoulder and the hip joint really are subject to lots of stress. When we walk, when we run, and when we jump, and tremendous pressure is put on the hip joint, and there can actually be physical damage. And so very often we'll have a very significant increase in pain because they step wrong, or because they play basketball, or because they jog. And that results from the physical damage that's occurring from the stress that's put on the bone. And one of the best studies that really showed us how common avascular necrosis is was a comprehensive study of sickle cell disease that was done in the 80s and 90s. And it plots the onset of avascular necrosis. And this is a slide that's sort of the opposite. That is, it's the time that in age that an individual goes to where they don't have avascular necrosis. And what you see is that by age 30 or so, about half of the individuals have avascular necrosis diagnosed. And if you look carefully, there's some differences. If you have hemoglobin SS alone, the number's about 50. If you have hemoglobin SS and also inherent alpha thalassemia, then it's actually about 70% of individuals will have avascular necrosis. Now, why does this occur? Well, the hemoglobin level is actually higher in alpha thalassemia with sickle cell, and so the blood is thicker and it doesn't flow as well. So avascular necrosis is one of the complications that occurs actually more frequently in individuals with higher hemoglobins than lower hemoglobin levels. So it's the opposite of many of the other complications. The other thing you'll see is that initially hemoglobin SC individuals have less avascular necrosis, that is their hips last longer, but as they get older actually they have more disease than SS pure. So older individuals will more commonly, with SC, will more commonly have avascular necrosis. And again, this is thought to occur because the hemoglobin is higher in these individuals. So this is a little different than many of the other complications where a high hemoglobin actually isn't the best thing in the world. Now, how do you make the diagnosis? Well, the other thing that's really tricky about this problem is that the pain usually isn't in what is perceived as the hip. The pain from avascular necrosis occurs in the groin, it occurs in the butt, and it occurs in the knee and the upper leg, the thigh. And this is called referred pain, and that's really occurs because the damage here irritates nerves that also feed the muscles that go to the buttocks, and also nerves that serve the rest of the femur and the knee joint. And so they become irritated by the damage that's occurring in the hip, but the pain is actually referred down the leg. Usually when the doctor does an examination, it's very easy to show that if you just gently rotate the hip joint with somebody laying down, it'll cause pain, and that's very diagnostic. Individuals with AVN also limp commonly. Brain X-rays are almost always useful to make the diagnosis. If they're abnormal, like this one is, that's all you have to do. Sometimes we do an MRI if the regular X-rays are normal, and that's very sensitive and very specific, and it's called sort of the gold standard, which means it'll pick up the AVN earlier, and the changes on the MRI are so characteristic that you can make the diagnosis without having more studies. Usually the MRI is just used to make the diagnosis, and then after that, the plain X-rays are used to follow the disease to see how it's progressing. And then the radiology or the X-ray changes and the clinical staging are what are used for management. And I've shown the hip again with one side being more normal, and then the other side, although this one also is affected by early AVN. This shows the humerus and the shoulder joint, and again you can see all this sclerosis from previous damage, the cystic areas, and the contrast to the surface. This is a normal humerus, and you can see how smooth and perfectly round it is. And you can see that this shoulder joint is flattened and it's irregular. And so this is an individual with advanced AVN. And with AVN of the shoulder, most of the pain is right in the shoulder joint, and it's made worse by motion. And staging, and I'm not going to say much about, but there's a staging system that goes from preclinical, where you may be able to see something if you look at disease of the hip, but really have no radiographic changes. Stage 1, the regular X-ray is normal, but the MRI will be positive. And then stage 2 is when you get very early changes in the head, but there's no collapse and there's no formation of little islands of regenerating bone. And then finally, once collapse occurs, it's called stage 3. And once the joint itself is involved, it's called stage 4. And stage 3 and 4 are more severe forms and are the ones that most often would require surgery. Are there any questions up to this point?
Dr. Eckman, no, there are no questions as of right now, but you are going, and your voice is lowering and increasing at times.
Okay.
I think it's when you move away from the mic.
I'll try and keep going.
Thank you.
Okay, so I'm going to talk a little bit about a management, because I think this is important. And these are just going to be general things, and each individual needs to be treated as an individual, and it needs to be done in partnership with a sickle cell expert and an orthopedic surgeon, and we'll come back to that again. But it's very important to realize that this is a partnership between 3 people: the primary sickle cell doctor, the individual, and usually an orthopedic surgeon. Certainly, it's very important that you diagnose and treat vitamin D deficiency and treat the vitamin D deficiency very aggressively so that it is in a normal range. Weight management is critical, and weight reduction. Pain management is clinical, and weight reduction is critical. And probably the best thing you can do for yourself if you do develop skeletal changes of any type is to really reduce your weight to at or below the ideal body weight. And this is one situation where it really pays to be thin. Pain management, we're going to talk about a little later. It's also very important, and it's completely different than trying to treat a pain crisis, because this is chronic pain, and it's bone pain, which doesn't respond well to opiates. So the treatment is primarily with the non-steroidal anti-inflammatories, things like ibuprofen and aspirin and Tylenol. Those are the mainstays. Physical therapy and occupational rehabilitation are very common things that need to be done. Physical therapy can keep your muscles strong, which will help protect the joint. They'll keep the joints flexible, which will also help protect the joint and the bone from damage, and that will reduce and minimize the pain. Very often when people develop AVN, they have occupations that really do aggravate this. They're on their feet all the time. Their job is in construction or someplace like that where you have chronic heavy lifting. And these aren't compatible with AVN, so you really do need to retrain and get into something that doesn't put as much strain on your joints and your bones. There are many other interventions that have been proposed, but there are no controlled studies. And the problem here is severalfold. One is we don't have good studies, and so the treatments that we have are quite limited. The other important thing, though, is that very often with the medical management that we've talked about already, you can prevent the symptoms from getting bad enough so you have to do anything more. And individuals with proven avascular necrosis in stage 1 and 2, about 60% of them will progress with symptoms at 3 years. The X-ray changes are small, it's about 7%, and if they're large, it's 80%. And one of the better studies that was done showed that the hip survival was 86% at 3 years. And so this is something that doesn't require aggressive therapy right away. The other thing that's very important to understand is that the symptoms wax and wane in many individuals. And so you'll have periods of time where the pain is increased, but there will be long periods of time where the pain is very well controlled with simple things like non-steroidals, or that you're not having any pain at all. And this is in the face of the fact that the X-rays don't show that change, as they stay the same and sometimes look very bad, but the individual still isn't having any symptoms. So the symptoms that you're having are really most important in determining whether or not something more should be done. Now, there are therapies that have been proposed for early AVN management. And one of the early ones, or surgical ones, was something that was called core decompression or multiple cutaneous drilling. And what's shown in the figure here is a very white head of the femur, because there's advanced avascular necrosis of the head. But it's still very smooth. There's been no damage to it hasn't collapsed. The joint is still in good shape, and the bone in the pelvis is still in great shape. So what the surgeons have done is they've developed techniques where they put 4 holes into the bone, into the neck of the femur, and it's done with a big thing, and that's called a core decompression, where they core out a piece of bone, or they put multiple needles in. And this is supposed to do 2 things. One, it relieves the pressure inside the bone so the blood flow is improved. And it also causes damage that improves the blood flow in the area. And so this is something that many orthopedic surgeons recommend early. A very important study was done, however, that I think is that you need to know about. And that was a study in which a large number of individuals were attempted to be enrolled into a study where the individuals were treated with, all of the individuals received physical therapy, and half of the individuals, the subjects, got additional core decompression of their hips. And there were 46 patients who enrolled. 8 dropped out, and more of the individuals dropped out who had the surgical intervention than the ones that just got physical therapy alone. The hip survival at 3 years was 80% in the core, and it was 86% in the patients who had physical therapy only. And if you look at this, the survival of the hips was identical whether or not they had just physical therapy alone or physical therapy plus the core decompression. And so the bottom line here, this is a small study, but this was pretty impressive. It wasn't powered, so it was possible that they were good. There might be a difference, but it looks like physical therapy alone is as good as, or maybe even better than, the core decompression in terms of having the hip survive long enough so it doesn't cause problems that require further surgery. And so I personally don't think that core decompression is a thing that we should do in most individuals. I think the other thing that's very important with this study is it really points out how effective physical therapy is in preventing the progression of avascular necrosis, so that AVN really needs to be treated with physical therapy as one of the mainstays. Now, once there's more severe involvement of the joint, a stage 3 or 4, where there's collapse and destruction of the joint, then the surgical management is total hip replacement. This, I'll show you an x-ray in a minute as to what those look like. The patient's pain, the impact of that pain on their quality of life, how much it impacts on the activities that they want to do, and vocational situation, all got the timing. And so the x-ray is not the major determinant of timing, and very often individuals have very terrible looking x-rays, but it isn't causing them pain, it doesn't interfere with their lives, and it doesn't have any impact on their occupation. And so those individuals we leave alone and we just follow them. All individuals really also have weight loss and physical therapy, even if they're going to have to go to surgery very quickly. And this is very important because the physical therapy will improve muscle strength. It'll allow the muscles to support the joints so they're not damaged. The weight loss is also critically important because it will reduce the stress that occurs on the prosthesis once it's been put inside the bone. And so both of these are very important to start before surgery and to continue after surgery. The major complications for this procedure are during surgery, and I'll talk about that in a minute, and loosening and infection. And with loosening, I'll show you, let me go on and show you what this looks like. And this shows on the left, is a very severe advanced case of avascular necrosis of the hip. And you can see on the right, this has been replaced, and this is dense white because this is a metal ball and neck of the femur that has been placed into the femur after the normal or the natural neck and head have been resected. So the hip part, the femur part of this is a ball, and in addition, there's a socket that's put into the pelvis. And so the bone is replaced again by a metal plate, and then in between here, there's a cushion, kind of a plastic that cushions the space between the two metal plates. And this is a very, very successful intervention. It almost always causes a very significant improvement in the pain, almost complete pain removal. You can see though that the metal is inserted into the femur, and one of the things that can occur is that there can be loosening of the metal where it interacts with the bone, and then that'll cause pain again, and you'll start having symptoms. Another thing that can happen is the lining, the plastic lining between the metal can wear out, and then that also can result in pain. And then infection of this is also a potential problem. The same thing can be done with the humerus, and the shoulder can be replaced. And again, here is the head of the humerus, and this is the prosthesis. And again, the normal head is, or the diseased head is removed, and a metal prosthesis is put in that articulates and forms a new shoulder. And again, this is also very successful in improving symptoms. And when the symptoms get bad enough, it's very successful in improving them. The replacement of the shoulder is extremely successful, but in this situation, the physical therapy becomes extremely important. And if you don't do that and continue to do physical therapy, the shoulder can freeze up, and you can start having symptoms with pain again. So A lot of people think the surgery is the end of the trail, but in fact, you have to continue the physical therapy to maintain the health of the joint after the surgery. We did a series looking at operative complications, and I think it's very important to understand that the outcome for the hip surgery is very good in terms of pain relief, but this is really a pretty serious undertaking in somebody with sickle cell disease. And in this series, where we looked at postoperative complications and operative complications, almost all of the individuals had some form of complications. Most of these were related to sickle cell complications and increased blood loss, but there were other more serious ones like acute chest, infection, and sometimes some neurologic and kidney problems, and a rare death. So the surgery is major surgery, and in sickle cell disease, that's something you have to take into consideration. Now, this is a very complicated table you can't read, but the other thing that we used to worry about is infection and failure of the joint, that is loosening of the hip. And one of the surgery residents and I did a study a long time ago in the 70s and 80s, and about 30% of the hips failed, and about a quarter of them got infected. And that was pretty much the same at Grady as it was around the country in terms of other reports. But more recent reports have really changed that. And so the outlook for the success of the hip joint replacement is much, much better now than it used to be. And so only about 3 to 5% of individuals will have a loosening of the joint or failure of the plastic between the two pieces of metal in the hip. And the infection rate now is about 5%, so it's much lower, and it is really very acceptable. So the long-term outcome for these are really excellent now once you get through the operative period. The total hip replacement recommendations from the NIH recommendations suggest that all individuals with sickle cell disease with intermittent or chronic hip pain should be evaluated for avascular necrosis with a history of physical and radiographic plain x-rays and MRI if the plain x-rays are negative. Avascular necrosis is treated with analgesics. You consult physical therapy and the orthopedic departments for assessment and follow-up because of the fact that the physical therapy is so important. And you want an orthopedic surgeon on the team in case surgery is necessary. They have also had a recommendation that patients who have asymptomatic, that all patients with advanced stages really need to be considered for surgery. That is, once you develop stage 3 or stage 4 disease, then the physical therapy becomes less effective. And if you do your physical therapy well and you're still having symptoms, that's really the time to think about having the hip replaced. So this is sort of the way I managed my patients, is that I felt that the medical management was really critical early in the disease. And I really fussed about weight loss, physical therapy. We aggressively corrected vitamin D deficiency, and we really had developed very carefully thought out plans for pain management that was individualized to the patient's needs. That is often taking into account their pain, but more commonly making sure that what we were doing was improving their function, was allowing them to continue to work and do things and be productive. And so rather than just a report of pain as an outcome, we were really trying to do pain management so that they were more comfortable doing more and had a better quality of life. We almost always had to involve occupational counseling because once AVN developed, it required some changes in the work environment to minimize the pain. We really tried to avoid opiate analgesics. They are not particularly helpful. If they're used, they have to be used sparingly, and they have to be minimized. With collapse, total hip replacement is a surgical intervention. Again, weight control and continued physical therapy are critical before the surgery and after the surgery. The timing of the surgery is based on your wishes, based on your pain, your quality of life, and how the pain is impacting on your lifestyle. And so you really have to be the key driver of the decision making. And the real bottom line is this is a very difficult complication because individuals are living longer. It's becoming much more prevalent, and we desperately need some really well thought out studies that to really figure out the best way of controlling this. Okay, I'll thank you now, and I think we have time for some questions. We're a little over time, but we started quite a bit late, so hopefully I'll have time for a few questions if you have any.
Yes, we do have a question. Dr. Eckman, my son just experienced benefits of physical therapy for AVN in his shoulder. The bone is restoring and range of motion regained. It was a comment, not a question.
Okay, great. I love those endorsements. I too have had a hip replacement. I lost weight and I did aggressive physical therapy, and I actually delayed my surgery by about 2 years. So physical therapy really is effective.
So we have another question. At what age can AVN manifest?
I'm not a pediatric physician, but I know we've seen it in individuals who are in their early teens. I don't know that it's very common before puberty. When I went to a mom, they have a very high incidence of avascular necrosis because they have high fetal hemoglobin and they have high total hemoglobin, so they actually have more AVN than we do. And I visited a pediatric ward, and there were many children who were in their the range of 12 to 13. So it certainly can occur in young individuals, but it becomes more common in late teens for children, and then over the lifespan of the individual, the frequency just increases. So right at the onset of puberty, I think is probably the most common onset. I'm sure there are cases where it's been detected earlier, but for having symptoms, I think probably you can think about puberty as being the earliest. Also, they'll say that if somebody's having pain in the groin or in the buttocks or in the thigh and knee, that it would pay to have that as a consideration, bring it to the attention of the physician, and hopefully they would get a plain x-ray, and if that was negative, consider an MRI, because I suspect that with certain types of sickle cell, it could occur even earlier than puberty.
Okay, do we have any more questions? Nope, it looks like we don't have any more questions. Thank you so much, Dr. Eckman, for your presentation. It was amazing. And thank you all for joining in today. And the video will be posted online within a week, so you will be able to check it out then. Thank you all. Have a good night. And thank you, Dr. Eckman.
Thank you for really enjoyed it.
Thank you. We always enjoy having you. This is really amazing. Thank you.
And we'll see you in Dallas.
See you in Dallas.
Yep.
Have a great night, everyone. Thank you.
Bye.